Hello everyone and welcome back to our MRCP Part 2 High Yield Revision Series. I am Dr. Waladin and here we go now.
Welcome everyone. Today we're diving into a rhythm that every clinician needs to recognize instantly, atrial flutter. Before we begin, I'd like to acknowledge the design of these materials by Dr. Wala Eldin Ahmed. The content of this video is for general information and educational purposes only, not a substitute for professional diagnosis or treatment. Now, look at the sketch on your screen. When you see that classic sawtooth pattern, your diagnostic brain should click immediately. Atrial flutter is a macro re-entrant tachycardia. What does that mean for the patient? It means the atria are firing at incredible speeds, usually between 250 and 320 beats per minute. But here is your first clinical pearl. The ventricles usually can't keep up. The AV node acts as a gatekeeper, often resulting in a 2-to-1 block. This is why on your exams and in the ER, you will so often see a narrow complex tachycardia at exactly 150 beats per minute. If you see 150 beats per minute, think flutter until proven otherwise.
To treat it, we have to understand the plumbing. Typical atrial flutter is a loop. Imagine a race car driving around the tricuspid valve. The most important landmark here is the cavo-tricuspid isthmus, or the CTI. This is a narrow corridor of tissue between the tricuspid valve and the inferior vena cava. In typical flutter, the signal usually travels in an anti-clockwise direction. This gives us those famous negative sawtooth waves in the inferior leads, 2, 3, and AVF. If the circuit doesn't use the CTI, perhaps because of a surgical scar or previous ablation, we call it atypical. Understanding this anatomy is vital because if we want to cure the patient, the CTI is exactly where the electrophysiologist will aim their ablation catheter.
Who is at risk? Well, flutter loves company. It is 2.5 times more common in men, and its incidence skyrockets as we age. Notice the strong risk factors listed in your notes. Anything that stretches the atria, like heart failure, valvular disease, or a pulmonary embolism, can create the perfect environment for this re-entrant circuit to start. Also, keep an eye on your post-op patients. Recent cardiac surgery or pulmonary vein isolation often triggers transient flutter. And don't forget the weak but important triggers, hyperthyroidism, sleep apnea, and even certain antiarrhythmic drugs that were meant to treat atrial fibrillation but ended up organizing it into flutter.
When a patient walks in, they might complain of palpitations, shortness of breath, or just feeling wiped out. During your physical exam, look at the neck. You might see rapid A waves in the jugular venous pulse. This is the atria fluttering against a closed valve. For investigations, the 12-lead ECG is your gold standard. If the 2-to-1 block is so tight that you can't see the flutter waves, you can use adenosine or a vagal maneuver to temporarily slow the gate at the AV node. This unmasks the sawtooth waves. A word of caution, always have a defibrillator nearby when using adenosine, as it can occasionally trigger a rebound increase in conduction or even AFib.
This is a critical branch in your decision tree. Is the patient hemodynamically unstable? If they have low blood pressure, chest pain, or altered consciousness, we don't have time for drugs. The answer is immediate synchronized DC cardioversion. Start with 70 to 100 joules. Because the patient is conscious, please ensure you have anesthetic support for sedation. We want to stop the circus movement of electricity all at once to allow the sinus node to take back control. Don't delay the shock to start anticoagulants, but do start them as soon as the patient is stable.
What if they are stable? Here we have a choice, rate control or rhythm control. But here's the reality. Rate control is notoriously difficult in atrial flutter. Beta blockers and calcium channel blockers like verapamil often fail to bring that 150 BPM down effectively. Because of this, our primary goal is usually to restore sinus rhythm. If you try pharmacological cardioversion with drugs like flecainide, you must co-prescribe an AV nodal blocker. Why? Because if you slow the atrial rate without blocking the AV node, you might accidentally allow 1-to-1 conduction, sending the heart rate to 200 plus BPM, which is life-threatening.
For long-term success, catheter ablation is the star of the show. It has a success rate of over 95% for typical flutter, and is often recommended even after the first episode because it's a definitive cure. Now, let's talk about stroke prevention. Atrial flutter carries a similar thromboembolic risk to atrial fibrillation. We use the same CHADS2 DS2 VASC score to decide on anticoagulation. Most patients will start on a DOAC, like apixaban or rivaroxaban, because they are easier to manage than warfarin and don't require constant INR monitoring.
We must be vigilant about complications. If left untreated, chronic high heart rates can lead to tachycardia-mediated cardiomyopathy. Essentially, the heart muscle wears out from overwork. Also, watch out for the amiodarone trap. While effective, long-term use can damage the thyroid and lungs. The good news? About 60% of cases are triggered by an acute, reversible cause, like pneumonia or a holiday heart alcohol binge. If you fix the underlying cause, the flutter often vanishes. But for those with structural heart disease, the path usually leads to the electrophysiology lab for ablation.
To wrap up, always refer to the latest guidelines, NICE in the UK or the ESC and ACC-AHA globally. They all agree on one thing: early rhythm control and stroke prevention save lives. Remember, C150 BPM, think flutter. Unstable, shock. Stable, ablation is your best friend. Thank you for your attention. Keep these notebook slides handy for your rotations. I'm confident you'll be the ones to catch that next sawtooth wave in the clinic. Happy studying.
If you like this series, please hit the like button and subscribe for videos like this. Bye for now.